Years ago when I was in medical school, we had a urologist come speak to us, and he asked a question, what's the function of the heart? And he said it was to pump blood to the prostate. I think that sort of emphasizes the enthusiasm of our next speaker, who's singly focused on pancreatic disease and is passionate about it. And so it's my true pleasure to introduce Dr. Tim Donahue, our Director of Pancreatic Surgery at UCLA, to give us a surgeon's perspective of pancreas cancer in 2016. Tim?
Thanks, Raman. Thank you for having me speak today. I'm going to close out this session so I get to say the final words. Jeff sounded a bit like a surgeon at various points, so that was really good, But they asked me to speak about a surgeon's perspective of pancreatic cancer circa 2016, which is where we are. So as most of you know, there are two main cancer types in the pancreas, so I'll just focus my talk now on pancreatic ductal adenocarcinoma. We're doing some really great stuff with pancreatic neuroendocrine tumors right now at UCLA and developing a peptide receptor radiotherapy or radioligand therapy. Perhaps you'll hear about that next year if I'm invited back. Outline of our talk, we'll just talk about the epidemiology and staging systems of pancreatic cancer. First, I know Jeff touched on this a little bit, but pancreas cancer this year just moved from the number 4 to the number 3 cause of cancer-related deaths in this country, and it's on the rise. It's thought that by 2020 or 2030, probably more around 2030, it's probably going to become the number 2 cause of cancer-related deaths. This is a slide from the Pancreatic Cancer Action Network. A reason for that is, as you saw, the survival is not really changing much, and the incidence is going up, probably in parallel with the obesity epidemic in this country. Staging system of pancreatic cancer. I know Jeff again touched on this, but I just wanted to make a point to you that this is the current staging system. The only way that they stage lymph nodes now is positive or negative. So there's no quantification of lymph nodes in the staging system of pancreatic cancer. I think that's going to change within the next year or two, where they're going to have different stages in terms of the number of nodes that are positive. But once you get nodes positive, you get 2B disease, and then stage 4 diseases with metastatic spread. So we don't really use the staging system all that much for pancreas cancer, but perhaps the new revised one we will. Distribution of cancers in the pancreas, right? Most of them occur in the head. I don't know why that is. There's more pancreas volume in the head. There's probably more inflammation in the head of the pancreas. Bile duct goes through there and causes inflammation in that region. But most of them occur, 3/4 of the tumors occur within the head of the pancreas. So I'll focus most of my talk on the head of the pancreas. So this is a surgeon's perspective of pancreatic cancers in the head for the most part. The staging system that we usually use more, it's more applicable than the AJCC staging system, was mainly developed by Matt Katz, who's at MD Anderson. And it's categorized as potentially resectable, borderline resectable, locally advanced, and metastatic, which I'll talk about each of them. But this borderline resectable term is like locally advanced light. It's tumors that involve part of the SMA up to 50% of the circumference, the SMV or portal vein involvement in an area which is reconstructible. I just gave a talk to our radiology residents and GI radiologists, and they weren't even aware of the staging system. So again, not really all that used, but we really do try to classify them in these stages, particularly for trials and whatnot. But in general, potentially resectable lesions first go to surgery. I'd say that's probably what's done at most centers, perhaps not MD Anderson, where there has been an inclination to give more preoperative therapy. Borderline resectable, locally advanced, chemotherapy under radiation therapy, and then surgery after that. And metastatic disease, chemotherapy and radiation therapy. Very, 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 very select few patients undergo surgery who have metastatic disease at presentation, possibly those just with oligometastatic disease, but very rare. Still waiting for better chemotherapies or regimens for pancreas cancer in order to have surgery be part of their treatment. Surgical treatment, body tail tumors, distal pancreatectomy and splenectomy. You should take the spleen out in all body tail tumors for lymph node sampling and to assure that those margins are negative. And head and neck tumors, Whipple resection or pancreaticojejunostomy. Two types of Whipple resections. There's the standard Whipple and the Pylorus preserving Whipple. We mainly do the Pylorus preserving Whipple at UCLA because it was first described at UCLA. So we're keeping with our traditions there. But if you have this operation at Mass General in Boston, they do standard Whipple. So some benefits and to each of them. But that's what the reconstruction looks like after a Pylorus preserving Whipple resection. And here it is where the standard Whipple, where just the antrum of the stomach is also taken out. Here's a picture of a Whipple resection that I did. Listening to Steve talk about post-ERCP pancreatitis. I don't know how that causes pancreatitis, and this does not. But anyways, pancreas likes surgeons better than gastroenterologists, I guess. I probably shouldn't say that in this environment, but there we go. So here, as you can see, this is the point where we're about to transect the pancreas. It's overlying the SMV portal vein there. We've got sutures around the arcades of the pancreas. This is after the pancreas has been transected, removing those last final parts off of the vein and the artery. You can see the SMA kind of poking out there near where the specimen is. It's really important to try and get within a millimeter of the lateral and posterior borders of that artery, especially for tumors that are in the head and or the uncinate process. And as Jeff showed here, here's a picture of a SMA skeletonization, which is what we try to do as much as possible on all cases. This is the reconstruction, so there's an end-to-side pancreaticojejunostomy that's performed in an isolated limb of bowel. This is what it looks like after it's completed. There are many ways to do it. There's always debate about leave a stent, don't leave a stent, et cetera. And there's no real best way to do this. This is the last part, the duodenojejunostomy for the Pylorus preserving Whipple. It's important to try to make sure that that's within 2 or 3 centimeters beyond the pylorus to try and prevent delayed gastric emptying. Luminal bleeding after a Whipple, that occurs 2-3 weeks is mainly from this location. Usually assume it's this location unless proven otherwise. It's the most common place of intraluminal bleeding after a Whipple. This is what it looks like after it's completed. So this is the completion of my surgical pictures. I just wanted to talk a little bit about what we're doing at UCLA. I think between MD Anderson, University of Colorado, and UCLA, these are probably the 3 busiest pancreas centers west of the Mississippi, so really have a great panel and some expertise here. I think we have a bona fide multidisciplinary program, and we're working really, really hard to make it better, even more cohesive, even more integrated. This is a picture of just some of the different people from different expertise who participate in our multidisciplinary program. I know that Sachin talked about ERCPs being done at high-volume centers. I really do endorse that. He said it a bit gingerly. I'll say it a little bit more boldly. I would even propose that I'd say that all patients with pancreas cancer should probably be treated at high-volume centers for their comprehensive care. There's some rich surgical literature that patients who are operated on for pancreas cancer at high-volume centers by high-volume surgeons just do better. And there was just a report from the California Healthcare Foundation that I think 75%, this was just within the last week or two, it was announced in the Cancer Letter, which I don't know if anyone reads it. It's like the tabloids of cancer research. It's one of my favorite things to do on Friday afternoon. But nonetheless, it said that 75% of hospitals in this state perform 1 or 2 pancreas surgeries per year. And the mortality of those patients was markedly higher than other hospitals. But 75% in this state. Either people aren't listening to me or I'm not doing my job, but nonetheless, I'm going to keep talking. UCLA, we've started this integrated practice unit. What's an integrated practice unit? It really came about, the concept came about in this Harvard Business Review article from about a year or 2 ago, which is focused on how healthcare is going to be fixed, the cost of healthcare, the delivery of healthcare, and whatnot. And one of the main tenets that they argued was to organize around in these integrated practice units. We call it IPU, not an IPA, but nonetheless, it's defined as a dedicated team of non- and clinical personnel organized around specific diseases to provide efficient and comprehensive care. IPU members, we meet frequently to review outcomes on their own performance, must see themselves as a cohesive unit, and co-locating staff and MDs in the same multidisciplinary clinic is just one component of an IPU. It's essentially trying to organize physicians around disease processes to live and breathe those disease processes together. So we've IPU'd. This is our multidisciplinary clinic workflow. Must have been I adapted this from the one at University of Colorado with Sachin and Rich Sulik. I color-coded it, so this is a new revised version of it. But essentially the point of it is to be able to have patients see experts, physicians from all disciplines who they need to see in one clinic, have appropriate radiographic studies and whatnot, and receive a defined plan by the time they leave the clinic. So they have a confirmed plan when they leave, and it's not anymore that when they leave that it's open-ended because the CT scan or MRI was insufficient. So we make sure that those are right, and a plan is developed. The specific goals of our IPU and an IPU are to work together as this team to provide efficient value-based care, to perform rigorous evaluation of outcomes, to expand enrollment in clinical trials, and to increase the number of patients who we get from those 75% of hospitals that only perform 1 or 2 a year. Anyways, I wanted to focus on improving treatment and outcome in patients with locally advanced borderline resectable pancreas cancer. That's one component of how we're working as the IPU to improve outcomes, and this is, I think, how I'll really talk about a surgeon's perspective of pancreas cancer in 2016. We at UCLA have traditionally given patients a prolonged course of chemotherapy or treatment before surgery, longer than other institutions, and we think that this is the right way to do it. Matt Katz and I from MD Anderson have debated and argued for, the last 5, 6, 7 years about what's the right duration of treatment, but he's not here. Jeff will have to represent him, so you're going to hear my side of the story now. As I said, these are locally advanced borderline resectable patients. Their tumors involve the local vasculature, so rather than taking them to surgery, putting them either through an extensive operation with a vein resection and reconstruction, or having them have a margin or positive resection, approaches to treat them with chemotherapy or radiation therapy first. We were one of the first centers to do this. Before, I'd say 1992, 1995 or so, surgery was not part of the algorithm, the treatment of these patients, but we were one of the first places to start it. You can see the time periods here at the top. We've been doing it more frequently, so we're getting a bit more aggressive with patients who are taken to surgery. But we've pretty much held consistent that we give a little bit longer treatment to these patients. So about 6 months of therapy, we think, is the right duration of treatment. We're taking out veins. We didn't used to take out veins. We're taking out veins now and reconstructing them, again, in the right patients. But our median survival is really, really excellent. I think that this is largely because that we're selecting the right patients for surgery, and we're probably just getting more chemotherapy into these patients because we're giving them more therapy before surgery. As Jeff had shown, the chemotherapy administration rate after surgery is somewhat low, and it's potentially better to give it before surgery. I told you about that our duration is longer. You can see here us versus them above, us below, and the duration is 6 months for us and shorter in other places. The CATS AL study is from MD Anderson. And the survival on the right there, now I know this is multifactorial, but I'm just drawing a correlation between duration and survival. And we think that this is for the borderline resectable, not the locally advanced group, but our survival of patients who undergo resection is really quite excellent. What percentage of patients who present with borderline resectable disease actually undergo an operation, given that we're giving longer therapy? Well, about 60%. So counsel patients tell them about 2/3 of them will be able to have an operation. The other studies is between 40 and 74.3%, so we're within that range. We're probably in the lower part of that range. But again, I think that we're in the range, and it shows that we're not just overly selecting patients for surgery, and their survival is probably because they're getting more chemo. Locally advanced, you can see here the duration of treatment, us versus them. It's variable at most places, but again, we really subscribe to that a median of 6 months of therapy, and again, our survival is really, really, really great. So we're proud of these statistics. Many fewer patients who present with locally advanced disease undergo an operation, so only about 22%, probably more selected. But if you look at our survival, right, so on the blue chart there, those are patients at UCLA with stage 1A and 1B disease, so 45 months, 36 months. And if you look at the survival of our borderline resectable and locally advanced patients who undergo therapeutic resection, the blue chart is therapeutic resection too, 62.2 months and 39.7 months, which is about the same as early stage disease. So I think we're achieving an excellent survival in those patients. The right is the patients who progress during therapy and don't undergo an operation. Their survival is markedly lower. I think that what this really shows is we're probably selecting the right patients to undergo an operation. I guess you could argue the converse, that we could have improved the survival of those patients who didn't undergo surgery, but I think it's the former. I just do. We make patients have, for the most part, 6 months of therapy prior to surgery. It's really hard to then do this huge operation on them and then ask them to have an additional 6 months of adjuvant therapy. So we've been trying to look at which patients would benefit from adjuvant therapy in addition to this prolonged preoperative therapy. And we did that by looking at a study of prognostic biomarkers. Anyways, you can see here the normal clinical histopathologic ones. We also threw in some molecular biomarkers, but the one that wound up being the most predictive on multivariate analysis was SMAD4. I know that MD Anderson has done a lot of work with SMAD4 in terms of disease progression and predicting where recurrences develop. But this is the survival curve of histopathologic response in SMAD4. So when deciding which patients need adjuvant therapy in addition to the long 6 months of neoadjuvant therapy, we strongly look at SMAD4 to select for those patients who would potentially benefit from additional therapy or still, have a poor prognosis in this specific cohort. And we've incorporated it into all of our pathology reports. And then finally, what we've most recently started looking for is are there a subset of patients who don't necessarily need that long 6 months of preoperative therapy? Can we find ones who will do well with surgery after just a shorter period, and we can save some of that treatment for the adjuvant setting? And so what we did to do that is this was just a recent study that's now in press and Journal of American College of Surgeons. But again, here's our treatment duration and survival, and you can see here that 2/3 of patients got 6 months or more of therapy. These are patients locally advanced, borderline resectable, who underwent resection. And those who received longer chemotherapy preoperatively, the greater than 6 months, had a better survival than those who received less than 6 months, again, supporting our approach to receive more chemotherapy prior to surgery. But when we did a multivariate analysis, univariate analysis, we found that those whose CA19-9 normalized during preoperative treatment did markedly better. It's kind of obvious. CA19-9 not really good at a diagnostic marker, but it's really good at following treatment response. So in those patients where it's elevated, it's really very helpful. Anyway, so if you look at the patients who CA19-9 normalized, the blue line there, versus those who did not during preoperative treatment, the ones who normalized did a lot better. And you can also see in the graph that's highlighted on the bottom right is those who's normalized in less than 6 months of treatment did really well. And those who did not still did okay if they got greater than or equal to 6 months. So what we're doing now is we're using this marker, CA19-9. So if you're getting treatment, we usually start the treatment for about 3 months, which is what most other places give. And if your CA19-9 normalizes, we're taking those patients to surgery at that point and saving some of that therapy for the adjuvant setting. But if the CA19-9 doesn't normalize, try and push them out another 3 months of therapy before having surgery. There's another concept that's kind of reached the surgical field for pancreas cancer is whether or not arterial resections, hepatic artery resections should be done and whatnot. We haven't started, but I'm tempted to start perhaps in those patients where the CA19-9 is normalized and they would benefit from a aggressive or local therapy. So In conclusion, pancreas cancer, really large disease burden in this country. It's becoming a larger disease burden. Fortunately, there's more money being spent by the government and foundations on trying to develop some better treatments for this disease. We're trying hard at UCLA too. This integrated practice unit structure that I talked to you about, it's a bona fide multidisciplinary program. It's efficient, it's value-based, it's innovative care for all patients who can often come from a long distance and whatnot. We're looking at many metrics about like how long it takes from our initial encounter to a definitive therapy, or how long it takes from surgery to they start on chemotherapy, and we're really trying to narrow those intervals as much as we can. I'd posit that treatment of patients with borderline resectable locally advanced tumors is becoming increasingly personalized, as I said, with a kind of our using CA19-9 as a marker to identify those who can receive shorter treatment preoperatively than those who need a little bit more. So it's becoming increasingly personalized based on our evaluation and accumulating experience with this group of patients. So I know we're behind, but went through a bit of information. But I'd like to thank you. Really enjoy coming to this conference and speaking.